I'm going to do in the next 15 minutes or so is to talk to you about amyloid heart disease and the current updates in diagnosis. Whenever we see thick walls, we need to ask a question why. Number one, it could be hypertrophy. We heard about it, which could be genetic, hemodynamic, or endocrine. Infiltrative could be amyloidosis. Storage, like the glycogen storage disease, Pompe and Denon disease. Now, it's a myth that amyloidosis is a rare disease. However, it's no more a medical zebra diagnosis. It is very common, and we need to actually have a heightened suspicion about it, and that is how we can recognize it and diagnose it. It is not rare, but most of the patients do not have a formal diagnosis. The number of patients with a formal diagnosis of cardiac amyloidosis is very small, and the large population without a formal diagnosis. It could be a wild type of ATTR-CM or a wild type of ATTR-CM, 12% of the low flow, low gradient degenerative aortic stenosis, which can be associated with it. In the classification, amyloid light chain, when you have A and the L is for the light chain. Amyloid transthyretin, when TTR added to A is for the transthyretin, and so on and so forth, when we classify them into different subtypes. The type of protein that is misfolded and the organ or tissue in which the misfolded proteins, amyloids are deposited, determine the clinical manifestation of amyloidosis. Normally, if you look at the electrocardiogram, you will find that the voltage is low. Normally, with the left ventricular hypertrophy, the ECG should also show you LVH. But in amyloidosis, you will find that even though the left ventricle is very thick, there is a pericardial effusion, a possible pleural effusion, but the electrocardiogram is a low voltage. This is pathognomonic for amyloidosis. You will see an increased thickness of the left ventricle wall, and there will be a granular appearance here also. Along with that, you will have an increased thickness of the right ventricle. This is what you are going to see in these patients with amyloidosis. So a thick left ventricle, a very small cavity, a large left atrium, pericardial effusion, and an increased atrial wall thickness. That is why you are going to have left atrial strain, which is going to be affected in patients with restrictive cardiomyopathy, because there is an infiltration of the amyloid into the left atrium as well. The interatrial septum is thickened in these patients. When we approach the diagnosis of amyloidosis, we have the monoclonal protein study, immunoglobulin free light chains, the serum, and the subcutaneous fat aspirates. So you can aspirate the subcutaneous fat and thereby diagnose if the patient has amyloidosis or not. This is the lab approach that you should follow: the echo, MRI, pyrophosphate scan, and BNP troponin, and you'll be able to come to a diagnosis in these patients. An early diagnosis in patients with amyloidosis is very essential, because then you can manage these patients. If you diagnose them late, probably you will not be able to treat them, and the prognosis will be poor in these patients. This is a case where you can see a thickness of the interventricular septum, mildly thickened, and it is not a classical example of amyloidosis. However, this patient at the end, and when you looked at one of the clues to it was the pericardial effusion, which was present here. And when you look at the bullseye appearance, you will not find the typical apical sparing that you see in these patients with amyloidosis. So what are the echo red flags here? Number one, you have the pleural and pericardial effusion. A thick right ventricle is very important. Thick valves are very important. The interatrial septum is thickened. This is what is going to give the clues to the diagnosis for amyloidosis. The stroke, because the left ventricle is small, there will be a low stroke volume in these patients and a paradoxical low flow, low gradient aortic stenosis in these patients where you have a degenerative aortic valve. They show a restrictive pattern of filling, the mitral valve inflow Doppler, the pulmonary vein Doppler, and the lateral mitral annular tissue Doppler imaging, where I said yesterday that you will have a 5 by 5 by 5 sign in these patients who have a restrictive cardiomyopathy, because the S wave, the E prime, the S prime, and the A prime will be reduced in these patients. If you look at the global longitudinal strain, you will find this is a patient who is with amyloidosis, and this is normal. This is apical sparing, and the apical sparing is because the fibrosis which is present around the base, the mid segment, is spared at the apex, and because at the apex there is no fibrosis, you will get a good contraction there, and the strain will be normal. It will be spared. Also, in patients with amyloidosis, you will have this is normal, where you have the flow curves here, and then the flow curve here in the left atrium, which is reduced in patients with amyloidosis. So what are the imaging targets in cardiac amyloidosis? This is a normal myocardium. This is the LVH, the tall R wave. This is a patient with amyloidosis, small waves here. You get on CMR, you will find a diffuse subendocardial late gadolinium enhancement and an expanded extracellular volume in these patients on CMR. A patient who had amyloidosis died because of sepsis. You can see the technetium pyrophosphate SPECT here, and look at the autopsy heart, left ventricular hypertrophy, and with Congo stain you will find the diagnosis of amyloidosis. Again, another patient, an older patient who was hypertensive also. Gradually the left ventricle became thickened. Technetium pyrophosphate increased uptake as compared to the ribs, and you have the SPECT imaging also showing the same thing here. As far as the CMR is concerned, you will have subendocardial diffuse late gadolinium enhancement in these patients with amyloidosis. The quantitative visual scoring that you can have from 0 to 3, it's the uptake as compared to the ribs, or you compare it to the contralateral lung, and then you have a ratio here where you can find out as to what the diagnosis could be. With a ratio of 1.7 of the heart to the contralateral lung of more than 1.7 or more, the diagnosis is nearly certain in these patients. Even in those patients where you do not have any technetium uptake, you will still find that these patients have amyloidosis. As far as the strain is concerned, you can utilize it for prognosis or to see the follow-up in these patients. You will find that in patients where there is an apical sparing, there is a further deterioration as time passes on, and this is what you can do in these patients with the strain imaging bullseye view. Cardiac amyloidosis has classically been characterized as a disease of the myocardium. You see it is present in the myocardium, but it infiltrates the valves. So from the myocardium, it has become a disease of the valves and of the interatrial septum. And then you can actually, and this is what is meant by the cherry on the top where it is spared. And this is a classical case of amyloidosis where you have the bullseye appearance of apical sparing. Now, when we look at the algorithm, there are clinical red flags, there are the echo red flags, and there are the CMR red flags, which you should keep in mind when you are looking at these patients with a high suspicion of amyloidosis. This is the pathophysiology, the process which takes place, results in restrictive cardiomyopathy, and then peripheral and or autonomic neuropathy in these patients. Another patient with the ATTR CM apical sparing. However, in another patient where there was a grade 1 uptake of pyrophosphate, the bullseye appearance was not classical. So it is not always that you will get an apical sparing in patients with amyloidosis, and you can get it otherwise also. For example, in patients who have reverse Takasubo or Danon disease, you will have apical sparing in these patients as well. CMR appearance in patients with cardiomyopathy, ATTR, and those with hypertensive heart disease having amyloidosis. Then you have the gross pathology here, thickening of the interatrial septum, of the valves of the left ventricle, of the right ventricle here. The uptake which you can see in this patient where the diagnosis of amyloidosis was made. This shows an heterogeneity in the uptake of pyrophosphate SPECT imaging. Coronary artery disease was ruled out, but it was a case of amyloidosis. The places where you can actually target the therapy in these patients. How can you follow it up? Because sometimes if you have patients who have infiltrated, the patients have the disease which has infiltrated the valves, there you can actually follow it up by looking at the valves, and you see that if the regurgitation becomes severe in these patients, as they progress, then you can identify the prognosis is worse if the TR and MR becomes more severe in these patients with amyloidosis. Another patient where the infiltration in the valves was shown by the histopathology, patients with amyloidosis, another case with amyloidosis. So the take-home message which I have here is, number one, the low voltage in context of increased echocardiographic wall thickness. This is pathognomonic. However, the low voltage which is seen in these patients with ATTR CM is in less than 50% of the cases. So it is not always that you are going to see a low voltage in patients with amyloidosis, number one. Number two, as far as echo is concerned, there is an increased left ventricular wall thickness, which can be with or without right ventricular thickness. There is a granular appearance, which is typical in these patients with amyloidosis, and an apical sparing, because the rest is infiltrated, but the apex is spared, and therefore you have this apical sparing, or a cherry on the top of the cake in these patients with amyloidosis. Then in cardiac magnetic resonance imaging, there's a diffuse subendocardial or transmural late gadolinium enhancement. And we had an excellent lecture on cardiac magnetic resonance imaging by Professor Tipu just about 2 days back. Then there is an increased myocardial native T1, an increased extracellular volume fraction, and an inability to suppress the myocardial signal with PSIR LGE imaging. Nuclear imaging shows to you the pyrophosphate uptake in these patients. The increased uptake definitely is in patients with amyloidosis. So these are the take-home messages which I have, but we must have a high index of suspicion in these patients who come to us with left ventricular hypertrophy. It is not always because of hypertension or because of hypertrophic cardiomyopathy. Think of the infiltrative diseases as well. Thank you very much for your patient listening.
Thank you, Dr. Kureshi, for excellent presentation and management of time. I can take one question.
थोड़ा सा लंबा क्वेश्चन नहीं है, rather comment. It's it's an excellent talk, very comprehensive. एक थोड़ा छोटा सा वो है, I think juniors काफ़ी सारे हैं बैठे हुए. हम अभी भी आई थिंक जो आपका पहला स्लाइड थी जिसमें आपने कहा इट्स नॉट अ रेयर डिजीज़, एक्चुअली हम इसको मिस करते हैं बहुत ज़्यादा, एंड आई थिंक ये बहुत इंपॉर्टेंट है कि वी शुड नॉट मिस दिस डिजीज़। ऑल्दो अब हमने उसको पकड़ना शुरू कर दिया है, लेकिन अभी भी हम जब पकड़ते हैं तो लेट स्टेजेस में वी आर डायग्नोजिंग द केसेस बट इन वेरी लेट स्टेजेस। सो आई थिंक वी शुड start picking up at an early stage, and 1 to 2 things which are important in picking up the cardiac amyloid at early stage. One is definitely the clinical suspicion. The second thing, the echo findings which you have described in detail, especially the strain. And on CMR, uh, T1 mapping actually is rather more important, and even if you are not getting the delayed enhancement in early stages, you may have increased T1 value in cases of amyloid. And as far as technetium pyrophosphate scan is concerned, it's positive only in ATTR type, not in AL type.
Not in
that's,
AL.
That's again an important thing. Thank you very much, sir.
Thank you very much, Dr. Tipu, for your comments. I think we really need to have a high index of suspicion. That is important. And we need to understand that the cases will increase now. As the age advances, we are going to see more cases with cardiac amyloidosis. And echocardiography is perhaps the most first diagnostic tool which you have for it, because it is cheap, available everywhere, and can be learnt with very minimal time.